present, I'd like to have him go first. I'll just go through confidentiality, and I believe his is case two. Um, so this information is confidential and privileged. It's protected under the HIPAA Act, and use of it, distributing it, copying it is prohibited. And double check if it's yeah. All right. Mr. Simmons, if you'd like to go ahead and unmute yourself.
Yeah, can you still hear me?
Absolutely. So you guys got dispatched on an 18-year-old?
Yeah, that's correct. For those of you who don't know me, my name's David Simmons. I'm a newer medic here with Clark County, but been a medic for a little bit back home in North Carolina. This is my first case review, so I apologize if I go off the rails at some point. But yeah, we were dispatched to a pedestrian struck by a vehicle on 205 southbound. Had a pretty quick response time. We were coming right from Salmon Creek, so we were on scene pretty quickly, just a couple of minutes. We initially thought it might end up just being a DOA. We found him unresponsive, laying on his left side. Did not appear to be moving or breathing. Immediately got him rolled supine, and he had some agonal respiratory effort. And I palpated a pretty strong central pulse initially. So we obviously didn't know anything about who he was, didn't have any demographics. The scene was very chaotic, lots of bystanders. We weren't really sure if anybody knew who this person was. And my main priority was just getting him packaged and getting off scene as quickly as possible. So our initial vitals, I think in the chart it recorded his heart rate is 82, but I was reviewing the chart and looking at the EKG strip. It was right about 150 initially when we got him on the monitor. Yeah, we got him. I delegated the mobilization. We got him fully immobilized to a long spine board with a C collar. Gave a couple of rescue breaths to clear the airway. And while that was happening, I immediately got on the radio and notified Southwest that we were going to be bringing him a full trauma. GCS3, agonal respirations, and I would just give him a more full report en route just to kind of get that ball rolling. Once we got him loaded up, we had a lot of extra hands. We had a supervisor on scene. I think we had at least 3 medics and 1 EMT fire rider in the back with us. So we very quickly were able to get a basic airway established, got him suctioned, got him exposed and did a full head to toe trauma assessment. Found the lots of airway and facial bleeding, multiple facial fractures, broken teeth, multiple jaw fractures. Chest wall was surprisingly stable. Lung sounds were fairly clear, but with some obvious gurgling from a suspected hemothorax. He had a closed right humerus fracture, a closed left femur fracture with obvious shortening and rotation of the lower leg, and his pelvis was grossly unstable. It was basically powder. We really couldn't palpate a whole lot of landmarks with it. So we got an IV established, started running fluids wide open. Got the pelvic binder in place to stabilize that pelvic fracture, and started really just working on getting a good solid airway, just because of the massive airway bleeding and those gurgling respirations. Once we got the iGel in place, we had a really great end tidal and again still strong lung sounds. So we just kind of let that do its thing. Didn't really have any concerns about the airway at that point. Once we had a better full set of vital signs, he was very tachycardic. Heart rate was in the 150s and sinus on the monitor. Couldn't get a good SpO2 on him, I think just because of all the core shunting. He had very poor peripheral perfusion, very weak peripheral pulses. And after we had all that figured out, I gave a second radio report to Southwest with just a full set of vital signs, so that they knew what they would be expecting. Tried 2 intubation attempts, was not successful, but I was really not terribly upset by it because the eye gel was working just fine. So I was happy to leave that back in place and just ventilate that way.
David, how come you guys decided to move forward with intubation?
Well, to be perfectly honest, had I at the time I was just finishing at the very tail end of field training.
Mhm.
So my field training officer was there, and also one of my supervisors was there. We had plenty of hands, and after that kind of initial scramble to get everything situated, and once we got our assessment done and most of the important things treated, there's a little bit of free time where we can communicate and come up with a plan. And had I been sort of on my own or independently released, I probably would honestly have not tried to intubate him just because the eye gel was working. But I'm in field training. It's one of my last shifts in field training, and it was one of the few higher acuity calls that I'd gotten to run in field training. So I figured, well, let me just take a shot.
Sure.
Um, it was obviously not an ideal airway to do it, not an ideal environment to try and intubate. It was my first intubation attempt in Clark County with some equipment I was not super familiar with. It was my first try with the McGrath,
Mhm.
and I'm also not very used to using the bougie. Just where I'm from, it was just not something routinely used. So unfamiliar equipment, suboptimal conditions, was really just not set up very well for success. But it was still worth a shot.
Yeah, and I'm not saying that you weren't set up for success. I think that this was a particularly difficult airway, especially as we go through what the patient actually had suffered. Um, I think that, your rationale is reasonable. You guys had 5 minutes scene time. You spent another 7 minutes en route. Sound like you guys got most of the gamut of your treatment initiated prior to even tra transport. So it seems reasonable with the support. I agree though, if in circumstances where you don't have that support or that consideration, if the patient is ventilating okay with the eye gel, knowing that this might be a pretty difficult airway given the anatomy and the bleeding, um, that may be something to pause on because the airway could become more difficult. Reseating the eye gel may become difficult to ventilate the patient. In the event that your arm was forced to secure an airway, you couldn't ventilate the patient with the eye gel. Would there be any other things that you would consider if your intubation efforts were unsuccessful and the patient was becoming progressively more hypoxic?
Yeah, absolutely. I'm a big fan of a surgical airway, and have done a couple, and I think it's a really good skill that I think we sometimes underutilize and get kind of tunnel visioned on just trying to pass a tube when it's futile or just really difficult.
Mhm.
So if that had been the case, right, if the eye gel's not working, adjuncts aren't working, then yeah, I wouldn't really had an issue going that route, but thankfully we didn't have to.
Absolutely. And that's actually one of the learning points for this one is if you were having to intubate this patient and you were unable to successfully intubate, that this is one of those ones that cricothyrotomy would really be on your radar. Thank you for presenting that information. And as you had mentioned, you had notified the hospital via radio, so there was no pulse air report. This was a self-referral from Mr. Simmons' field trainer. So that's how this particular case got presented, and highly recommend that you guys send me any cases that you think are worth as educational or really interesting. In fact, 3 of the cases of this month's presentations were all self-referrals. So in reviewing this case, I thought that these guys did a really excellent job. Scene time was minimal. They spine boarded him. They managed his airway, both BLS and ACLS or ALS as well, with the supraglottic airway. They got IV access. They treated him with IV fluids under the guise of permissive hypotension as the patient was hypotensive. They placed a pelvic sling in that time period, which remember was less than 5 minutes before they even got off scene. They got serial vital signs and they notified the hospital in a timely effort regarding the patient's condition. Really, I have no areas for a suggestion for improvement. Let me take a quick look to see who's on this. Actually, is there anybody on this call that wants to add anything regarding the pre-hospital care? Without hearing anything, I believe that the consensus is the same. So, in the patient follow-up, he arrived to the emergency room at Peace Health Southwest. He was intubated. He arrested shortly after arrival. A left thoracotomy was performed, and he was found to have a tension pneumothorax. A right chest tube was placed, and a femoral line was placed for access and for resuscitation. He went to the operating room. He had a exploratory laparotomy performed in pelvic packing. They closed his left chest, but as they were closing his chest, he went into torsades and ventricular fibrillation. They performed ACLS measures. They were able to get ROSC back shortly after initiating them. He went to the CT scanner to identify his injuries. From the CT scanner, they noted that he had a left renal artery injury, so he went to the IR suite for embolization of that left renal artery. He made it to the ICU. He was difficult to ventilate with frothy pulmonary edema, probably from his lung injuries and his lung contusions. He was started on Flolan, and in total, he received 14 units of red blood cells, 16 units of FFP, fresh frozen plasma, 1 unit of cryoprecipitate, 1 unit of platelets, and he was started on a Levophed drip. They determined that he was best supported at Emmanuel so that he can receive ECMO. And during his hospitalization at Emmanuel, he had much of his injuries repaired, but unfortunately, he went into PEA arrest. His family had made him a DNR at that point, and he had expired or passed away on the hospital day 16. His total injuries from his semi versus pedestrian accident was a right external capsular intraparenchymal hemorrhage, bilateral subarachnoid hemorrhages, posterior interhemispheric right tentorial subdural. He had bilateral pneumothoraxes and pulmonary contusions. He had a severely comminuted midface Lefort 2 bilaterally. He had a left internal carotid artery dissection. He had a left splenic renal laceration, a grade 4 bladder laceration, bilateral scapular fractures, a right pubic rami fracture, left sacral fracture, left femoral shaft fracture, left distal tibular fracture, and right humerus fracture. He was multi-systems trauma for sure. So in reviewing this case, I think that the best teaching point is to talk about this Lefort fracture because really there's not much for me to add to the pre-hospital care. So Lefort fractures are fractures that are determined off of the fracture line of the patient's skull or face. These are transverse fractures on the weakest point of the facial bones, and that was first described by René Lefort in 1901 when he reviewed cadavers with these injuries. The mechanism of injury of this type of fracture is usually a high-speed deceleration where the face strikes an object. Sometimes that's a dashboard, sometimes that's the pavement. And so Lefort 1 is a fracture through the upper maxilla, separating the maxilla from the frontal bones. Lefort's 2, which this patient had suffered, is a facial fracture that extends up into the inferior orbital nasal bone. This patient had bilaterally, so this portion of the patient's face was mobile. And then a Lefort's 3 is a fracture that goes past the zygoma through the orbital wall, through the nasal bone, and separates the entire face from the skull base. So emergency treatment for these patients is going to be highly ABCs while they're trying to get them ready for operative repair. These are patients that are markedly difficult to intubate, especially as we talk about bleeding. Usually there's copious amounts of bleeding, distorted anatomy, and instability of the face. So if oral intubation is unsuccessful and they don't have any contraindications for nasal intubation, one of the options is to do fiber optic nasal intubation so that they can repair the internally fixate the fracture fragments of the face. But if that's unsuccessful, either a temporary cricothyrotomy or a temporary tracheostomy is placed in order to ventilate these patients and to help with their breathing, but also for their surgical repair. I found a particular case study that I thought I'd talk a little bit about, but recognizing that we're not going to do this in the pre-hospital setting, or at least very, very unlikely. So in this particular case, I had a 27-year-old who was awake, alert, and oriented, had suffered some severe trauma to his face only. Um, they had taken a picture of him. He had a Lefort's 3 fracture. They talked about copious amounts of nasal and oral bleeding, multiple lacerations. They called his anatomy a dish face deformity, where it's kind of flat. If you can see this, you can see that the teeth that you actually see are going to be the maxilla. So his upper teeth are his maxilla is fractured and displaced forward, so the oral opening is very small. And then he has this drop jaw. This particular patient, as they were getting ready to work on repair of his fractures, he couldn't tolerate laying flat because of the bleeding, causing him to feel like he was suffocating, but he also desaturated. So at that point, he had no airflow coming from his nose. So he was not a patient that would be a candidate for nasal intubation. And and the other thing is that the doctor who would be performing the tracheostomy did not feel comfortable with him not being able to lay flat and with him kind of jutting forward so that he can ventilate. So they ended up doing this is a reconstruction of his facial anatomy. He had a mandibular septal fracture. He had bilateral maxilla fractures that extended into the infraorbital section of his face. So what they ended up doing is that they had another surgeon place his finger in this patient's mouth in order to reduce the maxilla fracture. So he placed his finger into the back of his roof of his mouth where the soft palate was, pushed up and forward in order to open up his oral airway to be able to fiber optically intubate him orally. I don't see us doing that in the pre-hospital setting, but just to kind of give you a good idea of how difficult these airways can be, and really a great job with paramedic Simmons and Costa regarding this patient's resuscitation and care. So as for the Southwest region protocols, um, this patient met red criteria, high risk for serious injury and regarding to the trauma injuries. So he will just kind of review that penetrating injuries to the head, the neck, or torso, and proximal extremities. Remember, this might be it's seemingly as benign as a pneumatic nail through the chest. Any, oops, sorry, any skull deformities, suspected spinal injury with new motor or sensory loss, chest wall instability, or suspected flail, suspected pelvic, suspected fracture to or more proximal long bones, degloving or pulseless extremity, amputation proximal to the wrist or ankle, and tourniquet use. I'm not going to go over the vital signs because it's pretty, vital sign criteria is pretty nuanced, and you guys can review that on your own for interest of time. And then the other thing I wanted to remind us is that this patient absolutely is a patient that, or patients like this patient are absolutely a patient that may need to have their airway secured by surgical airway. So a reminder that surgical airways in the form of cricothyrotomies are going to be done on adults. Anybody under the age of 12 will get a needle jet cricothyrotomy. So these are a procedure that should be performed on life-threatening upper airway obstructions where other measures are unsuccessful or unfeasible. Management identified the cricothyroid membrane, incise with a vertical incision, make a small horizontal incision through the cricothyroid membrane, insert a finger, dilate, insert bougie into the trachea to secure and not lose track of your incision and your anatomy. Place a appropriate sized trach tube over a bougie into the trachea, confirm placement. Right. So does anyone have any questions or concerns regarding this particular case before we move on to our others? All right. Next case is of a 61-year-old male. EMS got him as a shortness of breath case. When they arrived, the patient was alert. His airway was open. He was non-labored. He was speaking in full sentences. They noted that his lung sounds on the right side were diminished, as well as extensive subcutaneous air right greater than left of his chest extending into his neck. His skin was pink, warm, and dry. Vital signs were obtained 3 minutes after patient contact. Heart rate noted to be 82, blood pressure 171/95, respiratory rate at 20, and a room air sat of 96%. His past medical history included COPD and depression, and the meds that they had documented for him was albuterol, aspirin, Chantix, metoprolol, sertraline, Trelegy, and Zofran. The history that was provided to EMS was that he was post-op day 1 for a right upper lobe resection and that he was discharged earlier that day. He developed sudden onset of shortness of breath all of a sudden and noted that his throat felt like it was swelling. The vital signs that I reported at 3 minutes were in the last slide, and then at 10 minutes, an 18 gauge IV was established. The medics stated, actually, I'll talk about the shirt removal for in the ambulance because I believe that's how they documented it. At 11 minutes, another set of vital signs were obtained. He's still not tachycardic. They didn't record a blood pressure. His respiratory rate's 18. SpO2 is 97%. He's still on room air, and his end tidal is 38. At 13 minutes, they obtain another set of vital signs, largely unchanged. He's still hypertensive, but he's not hypoxic. He checked the blood glucose, which was 99. And at 15 minutes, they got a 12 lead EKG. There's some artifact, obviously, in the leads 1, 2, and 3, but ultimately it looks sinus rhythm, no evidence of arrhythmia or a STEMI. They initiate transport at 16 minutes. At 19 minutes, well, after transport, they documented that they removed the shirt from monitoring. And at that point, they noted that there was severe changes in swelling to the right chest, shoulder, right neck without stridor. When they removed the shirt, they were concerned about further deterioration, so they had diverted to pick up 2 fire riders. And initially, they were planning to go to Peace Health Southwest, but given this progressive change in this patient's anatomy and concern for impending um, airway arrest or airway decline, they decided to divert to Legacy Salmon Creek. They attempted another IV at 19 minutes. First one was unsuccessful. The second attempt was successful at 22 minutes. They record another set of vital signs. Still, the patient is pretty stable in regards to his vital signs. At 25 minutes, they contact Legacy Salmon Creek Online Medical Control for airway guidance. They were told to give the patient 10 milligrams of dexamethasone and 0.04 milliliters of racemic epi. I don't particularly know the discussion about what they had with online medical control. Maybe they felt that this was an anaphylactic or a reactive airway issue. The patient had reported to EMS en route that he was having chest pain, but it was deemed to be most likely pleuritic. At 32 minutes, they get another set of vital signs. He's still pretty stable, not hypoxic, and not tachycardic, not hypotensive. And at 38 minutes, they arrive to the hospital. They notified Legacy Salmon Creek through Pulsera as a red patient. The documentation in Pulsera was that they were coming from home, chief complaint of shortness of breath at a specific time, and had a nodule moved from the right upper lobe yesterday, discharged earlier today, subcutaneous emphysema over the right chest, room air sats of 96%. They did record a full set of vital signs. really a complete and detailed Pulsera, even as painstaking as it may be with your critical patient, it's really helpful for us. In review of the pre-hospital care, thought that they did a lot of really good care and treatment here. So early serial primary surveys, IV access early and getting a second line, exposing the patient's chest that allowed them to identify things that weren't necessarily noticeable without removal of the clothing, which led to appropriately the patient being diverted to the closest hospital to ensure that his airway didn't further decline, as this might be a difficult intubation given the distorted anatomy from subcutaneous emphysema. They still got a 12 lead, and I thought the decision making was really sound for this crew and for this patient's care. I really have no areas for improvement. Anybody have any questions, thoughts about this case? Unfortunately, this medic was unavailable, and she has 2 cases in this month. In the emergency room, they got some further details about the patient. So he was post-op day 1 from a partial right lung mass wedge resection. During his hospitalization and procedure, he had a chest tube placed, which was removed, and as noted before, he was discharged that day. Initial vital signs when he arrived to the hospital: heart rate of 81, blood pressure 149/95, satting 92% on room air, and breathing 18 times a minute. The ER doctor documents severe crepitance to the neck and bilateral chest with decreased breath sounds on the right. They performed a chest x-ray that showed a moderate to large right-sided pneumothorax, and a pigtail chest tube was placed. The patient continued to have shortness of breath and not significant change in the subcutaneous emphysema. So the ER doc at Legacy Salmon Creek contacted the cardiothoracic surgeon who had performed the procedure the day before and accepted him in transfer to Peace Health Southwest. At arrival to Peace Health, he was still short of breath. The ER doc at Peace Health had obtained a chest x-ray. It looked like the chest tube was not in the thoracic cavity. A CT scan was obtained to confirm that, and ultimately the ER doctor placed a pigtail catheter and placed it to suction. I'll show you guys some CT images of this patient in chest x-ray. So this is the CT scan. You can see the lung parenchyma on the patient's left. It's fully expanded up into the thoracic cavity. The right side, all of this black represents air in this particular case. So it represents a pneumothorax that is persistent with compression to the right lung. Normal lung tissue, thoracic tissue, in this case, should be solid like this. You can see all of this black here represents subcutaneous emphysema, right greater than left, and up into his neck as well. And then this x-ray down here is post chest tube placement. They used a pigtail catheter, so that's why it's not that like thick straw that you might see in a normal trauma patient that gets a chest tube. So this here is a mobile, flexible catheter that extends up to the apex of the right lung with reinflation of the lung. He was admitted to the hospital. His chest tube was placed on suction for 24 days or for 24 hours with improvement in his subcutaneous emphysema and resolution of his pneumothorax. He was clamped, and they got serial x-rays to ensure that he wasn't developing a pneumothorax anymore, and he was ultimately discharged on hospital day 3. So I thought for this particular case, the subcutaneous emphysema is something that we don't typically see for spontaneous or trauma pneumothoraxes. So these might be more related to complex cases, such as in this particular case, a lung wedge resection. So I thought it'd be a good chance to talk to you guys a little bit about what exactly happened for that patient. So a lung wedge resection is a surgical procedure that removes a section of the lung tissue. There's many lobes of the lung, And usually this resection occurs when they want to have a better idea of a area of concern in the lungs, such as a nodule. It doesn't remove the entire lobe, it just removes a wedge from that lobe. So this patient had a lung resection off the right superior, but likely apical lobe. And then they remove that tissue so they can have a better idea under pathology evaluation for potential cancerous tissue. How is it performed? Usually it's video assisted thoracic surgery, so video and high minimally invasive surgery, where if they have difficulty in gaining access, they might perform a thoracotomy and then spread the ribs to be able to physically go into the space and remove either the section in question or to handle any bleeding. And it usually takes 1 to 2 hours to perform. The recovery is anywhere from 1 to 4 days in the hospital, and the major issues usually have to do with pain control and physiotherapy and exercise. They do end up getting a drainage, not always a chest tube, but drainage during this procedure to deal with any bleeding and or pneumothorax. Then once the patient is deemed safe for discharge, the chest tubes usually are removed. And complications with, so this is a cartoon of a resection, a wedge resection of what that might look like of the questionable area of a lung nodule. The complications with this procedure can be air leakage from the lung, pneumothorax, pneumonia, bleeding, infection, blood clots, pain, arrhythmias, a bronchopleural fistula, complications from anesthesia, and rare but possible lung torsion. And in reviewing our protocols, the protocol that best suited for this presentation is the respiratory distress protocol. Although we have components of the respiratory distress protocol, including upper airway obstruction, asthma, COPD, insufficient respiration, and pulmonary edema, I don't believe that we really have anything here that best matches with this patient's presentation. As mentioned, the online medical control recommendation was kind of to treat it for like almost a little bit like anaphylaxis, but with the racemic epi and the steroids. But this patient had a post-op complication of a pneumothorax with air escaping into the chest and the neck. Any questions or concerns regarding this patient? Really atypical presentation for us in the pre-hospital setting can be quite dramatic in presentation with the amount of swelling, kind of almost think of it as like a balloon. And ultimately, if this patient's respiratory efforts declined, you had diminished breath sounds and examples of air in the wrong space that this patient, if things were kind of escalated, may need a thoracentesis, a needle decompression for a pneumothorax. All right, moving on to case 3. Case 3 is of a 63-year-old female. EMS was called for chest pain. They found her sitting on the floor. She was estimated to be about 280 pounds. She was alert. She had an open and protecting airway. They noted that she was pink, warm, and clammy. There was no active bleeding, and that she appeared to be in distress. Vital signs were obtained prior to EMS arrival or to transporting agency's arrival. They noted that her heart rate was not recorded, but her blood pressure was 178/99. Respiratory rate was not recorded. SpO2 was 100. Past medical history was reported as none, no medications. And the patient had developed chest pain the night before. She woke up that following morning with substernal chest pain that was non-radiating, and she felt short of breath, prompting EMS's call. First on scene was fire that was only a few minutes prior to transporting agency's arrival. they got this call at 4:09 in the morning. They got a 12 lead within 5 minutes of first patient contact, which showed this. Looking at this, she's got bradycardia rate of 57, narrow complex, appears to be no obvious heart block, although there's a little bit of artifact in the tracing, and then no obvious ST elevation or ischemic changes noted. At 6 minutes, they obtain another set of vital signs that now include a heart rate of 57 and respiratory rate of 23. Her room air sats were 100%. Her end tidal was 35, and she was given full dose aspirin. At 16 minutes, another set of vital signs were obtained. She's more bradycardic at 46. Her blood pressure is 139 over 101, and she's becoming tachypnic at 24 with a room air sat of 88%. Her end tidal is 26, and they checked her blood glucose, which was 143. They initiated transport at 18 minutes. An IV was established, and following the IV establishment, she vomited. The transporting medic had requested a fire rider, and she was given 8 milligrams of Zofran a minute later after she vomited. At 22 minutes, they get another set of vital signs. Her heart rate now is 38. They don't record a blood pressure. I'm not sure if that was because it was not palpable. Her respiratory rate's 25, and she's got an SpO2 of 100. They didn't document that they had placed her on oxygen, but I suspect that they did. End tidal was 20, and she became unresponsive with a left-sided gaze and snoring respirations. They thought maybe this was related to a seizure, so they gave her 2.5 milligrams of Versed, and they notified Peace Health that they were changing the patient status from yellow to red. They obtained another 12 lead following this change in the patient's mental status. Now this is looking pretty concerning for potential STEMI. Going through this, she's still bradycardic. Now her QRS is pretty wide. When you look through here, you look for the things that you can identify, and she appears to have ST elevation in her anteroseptal leads. This is likely ST depression in her inferior leads, knowing that you've got this elevation, and you'd actually can say that she's got elevation throughout all of her precordial leads, and that you would probably call this ST elevation in her lateral leads of 1 and ABL. Again, there's a lot of artifact that makes this a little bit difficult, but when I was preparing this case for reviews, it looks like there might be a 3rd-degree heart block if you look at V2 and march out here to here to here, although it's hard to tell with only one lead that shows that there's AV dissociation. So difficult, but great to recheck the patient, reassess the patient following a change in their mental status, including vital signs in the 12 lead. They identified her as being a STEMI. They placed defibrillation pads and notified the hospital now that she was a STEMI activation. They lost their IV. They placed a left humeral IO, and they gave her another 2.5 milligrams of Versed because they were having difficulty with ventilating her. They placed her on a non-rebreather. Of note, she was a language barrier. They didn't document what her language was, but they documented that she was Hawaiian descent, so some language, maybe tag along. And at 30 minutes, they repeat another set of vital signs. She's got a heart rate of 48, no blood pressure documented, respiratory to 29, SpO2 of 80%, and end tidal of 17. At 33 minutes, they arrived to the hospital. She's still unresponsive. Pulse is 45, blood pressure 120/76, respirators are 24, SATs now 82%, and end tidal of 15. This is the Pulsera notification of them changing to red, coming from home, chief complaint chest pain that started the night before with a almost complete set of vital signs, just missing respiratory rate. But they at least have an SpO2 in there. Although, as you guys know from reviewing the treatment, that she declined and she was no longer a normal ventilations. This was just the documentation of the communication of the updates on the patient's condition. So in reviewing this case, early 12 lead obtainment, aspirin, IV access, identification of the patient status changing both with the hospital, but in real time and then reassessing the patient to be able to quickly identify that her condition now warranted an activation with a team to be mobilized for her for the cath lab. And then, given the time frame that they had from her decline, really not a bunch of time for them to aggressively manage her airway, and then reasonable for them to consider Versed for possible seizure activity, but likely she had probably syncopized or became underperfusing that led to her unresponsiveness. When she arrived to the hospital, she was hypotensive and hypoxic. They intubated her with etomidate and rocuronium. Rocuronium because although she has no past medical history, they don't know if that's because she never goes to a doctor and to avoid any potential for hyperkalemia. They didn't document, at least did reduce dosing because of her hemodynamics, but likely she did. 12 lead showed a continued STEMI. She got ROSC and arrested again in VFib. They shocked her twice, and they decided to terminate resuscitation at 5:28. It's a little unclear why they determined to stop resuscitating her, probably for the duration of time since 4:09. She probably showed around 4:45, and that was about a 45-minute cardiac arrest. So that's likely the reason why they discontinued any continued resuscitation. I'm not sure about the no meds though. So in reviewing this case, I have to admit I was kind of reaching about what would be like the educational point, but I thought maybe the bradycardia would be something that we could look into a little bit. So with the patient having anterior and septal changes in ST elevation concerning for potential LAD occlusion, I kind of dived into that a little bit further. And the LAD artery is infranodal, meaning that it is going to be supplying the conduction system below the AV node, so that puts them at higher risk of presentation for bradycardia as well as heart blocks. So the importance of getting a good 12 lead and serial 12 leads. This picture here shows you that the SA node 60% of the time is perfused from the right coronary artery and 40% from the left circumflex, and that the right coronary artery is also responsible for 90% of the time perfusing the AV node. And then as we go down the conduction system, it's more LAD and left circumflex as the predominant perfusion for the conduction system. So if there's an injury to this artery, it's affecting more of the lower conduction system, which if it's below the AV node, we'll see, or a low presentation, you're going to see escape rhythms, bradycardia, YQRS, junctional rhythms. So that kind of gives you an idea of what you may potentially see in this patient's progression. Not everybody that has a STEMI is going to, or an LAD STEMI is going to be bradycardic, but if your first presentation is bradycardia chest pain, this may be legitimately an MI, and be on the lookout for blocks in malignant bradycardia episodes. And then when in that research of presenting this case, bradycardia with chest pain is highly concerning for possible MI. So just be aware of that as well. In regards to our protocols, chest pain, ACS, treat as a universal patient, obtain a pulse ox. Our goal for pulse ox is between 94 and 98%. We're not looking for 100%. SpO2, get a 12 lead. Our KPIs are for within 10 minutes of patient presentation. Give aspirin unless there's a contraindication. Document the contraindication, which is allergy, active bleeding, liver disease, or that they can't take it because they're already on anticoagulation. If the systolic blood pressure is greater than 110, consider nitroglycerin, 0.4 milligrams every 2 minutes. May repeat every 3 to 5 minutes up to 2 more times. And if the patient has evidence of a right-sided MI, you may want to be cautious about giving nitroglycerin. If they're on a phosphodiesterase inhibitor such as sildenafil, Viagra, Cialis, or Levitra, you should not give nitro. And you should have IV access, preferably prior to nitro administration. You can also give fentanyl. If they're hypotensive, you follow the shock protocol. If they're meeting a STEMI criteria, which means that they have more than 1 millimeter or greater ST elevation in 2 contiguous leads, and they don't have a pace rhythm or a left bundle branch block, you would want to activate the hospital for a potential STEMI. And remember, both Peace Health and Legacy Salmon Creek have capabilities for STEMIs now, with the exception of a few non-coverage hours or days. Notify the emergency room as soon as possible, even if that means that you notify them by radio and then put it in Pulsera. Once the STEMI activation has been initiated and confirmed by the ER doctor, at least for Peace Health, then the STEMI team has 30 minutes to arrive to the hospital to get the patient to the cath lab. I'm not sure if you guys are aware, but at Peace Health, when you send your 12 lead EKGs, the ER doc that is closest to the charge nurse has to review the 12 lead and determine if we're going to activate as a STEMI or not. If we decide to not activate as a STEMI, we still call it a code 3 chest pain and repeat the EKG when you guys arrive and potentially upgrade at that time. So if you notice the verbiage of we'll go ahead and upgrade when you arrive, it's because they deemed it not to be a STEMI on the pre-hospital 12 leads. So the importance of making sure you have good quality 12 leads as well as your most convincing 12 lead for a STEMI to be sent. I've had at least one case where EMS had sent a 12 lead that did not meet STEMI criteria, but when they arrived, they showed me other 12 leads that did meet STEMI criteria that they did not transmit. Always check OCS status for availability to accept suspected STEMI patients. If there's none available in Clark County, you may need to divert to Portland and contact medical control if divert's not practical with traffic. If the initial 12 lead is not meeting STEMI criteria, don't stop there, repeat it so that we can have serial 12 leads and ensure that the patient doesn't have progression of their MI that's showing up with ST elevation. All right, anybody have any questions or concerns for that particular case? All right, last case. Thanks, guys, for your attention. So this is a case of an 86-year-old. So you may have heard or been in some meetings that we're trying to do one refusal for every case review. So it's an 86-year-old female that had fallen. When EMS arrived, they were notified for a possible fall. They arrived to find her alert, open and protecting her airway, no active bleeding, pulse was present. They obtained a set of vital signs at 6 minutes after patient contact, noting that her heart rate was 81, her blood pressure is 142/90, respiratory was 16, and SATs of 99%. She lived in her own home. Family, I believe, daughter and son-in-law had come over to find her. Past medical history, they documented was anxiety and they documented no meds. EMS was met by the son-in-law. The patient was inside, unable to get up, and she was last seen an hour ago. For whatever reason, they came back to check in on her and she couldn't get to the door and they couldn't get in. The patient had reported to EMS that she had a mechanical fall, falling onto her buttocks. She was on they documented in the narrative that she was on aspirin, although it wasn't here in the meds. No loss of consciousness, not on thinners, and that she had no injuries and wanted help to get into a chair. They assisted her to her chair and they cleared 15 minutes after patient contact. There was no Pulsera because she was not transported. And in review of this particular case, they did get a full set of vital signs. They obtained a HPI that included didn't hit her head, no loss of consciousness, not an anticoagulation. And they documented a physical exam, stating that she had no neurodeficits, she had no injuries, and areas for improvement. And this may be hindsight is 2020, but she She presented to the emergency room and fall the next morning and said that she had no idea why she had fallen. So there's no clear indication for a fall. It's not mechanical, it's syncope. Um, and then she had stated that EMS had picked her up and put her in her chair. And when she tried to get up later, she fell again because she couldn't ambulate from her injuries that she had from the first fall. So areas for improvement, be really very careful about patients that don't really recall what happened to them when they had fallen because there's a potential for near syncope or syncope. And as a personal experience, for whatever secondary gain, patients may not want to come to the hospital or financial reasons, losing independence, and that they may say they have no injuries, but I think it's a really good practice to have them ambulate at their baseline. I personally had a patient at a grocery store who said that she was fine. We put her in on the bench, and she had a hip fracture, but was going to let us leave her there as until we tried to ambulate her before she left. The second presentation, I met her in the emergency room. She said that she was transported by ambulance, the second one, but we can't find it in any of ESO or CAD, so that may not be accurate. So when she arrived, she had told me that she had fallen twice. She doesn't know why she fell either time. The second time she tried to get up and she again doesn't know why she had collapsed to the ground. She was complaining of rib pain, shoulder pain, and pelvis pain. In the ER, we worked her up for syncope as well as injuries from her fall. She had labs, a 12 lead, a CT of her head, a CT of her chest, abdomen, pelvis with thoracic and lumbar reconstruction. She had multiple fractures. She had a comminuted left superior and inferior pubic rami fracture, left sacral ALEF fracture, left clavicle fracture, and rib fractures second through fifth. No pneumothorax associated with it. I pulled up the pelvis x-ray to kind of just show you guys what we're looking at. She's a little rotated. She's osteopenic. This should be like white contiguous, but you can see that some of it's a little bit sparse and that represents osteopenia. When you look at the pelvic ring, it's not symmetric. Again, she's a little under rotated, but you can see that her rings should be symmetric and she's got a fracture here and a fracture here for her pubic rami fracture, superior inferior pubic rami fractures, and also a sacral fracture. She was admitted to the hospital. Orthopedics was consulted regarding her injuries. They deemed her not operative for her pelvis fracture and non-operative, no fixation, no rib plating for her rib fractures. During her hospitalization, they worked her up further for her syncope. They noted that while she was on telemetry, she had multiple paroxysmal AFib with RVR that might have likely contributed to her syncopal episodes. She was started on metoprolol and digoxin during the hospitalization, switched over to oral metoprolol and dabigatran and amiodarone for discharge. They did do an echo because there's potential for valvular issues causing or structural heart issues causing syncope. They found her to have moderate aortic stenosis, which, although this could be a cause of syncope in itself, they felt that her syncope was likely related to her paroxysmal AFib with RVR that was present multiple times during hospitalization. She was discharged on hospital day 7 to a skilled nursing facility. So, who knows if she actually was transported or not by EMS the second time, but her whole hospitalization, she said that she didn't know if she tripped or fell. So we'll call it syncope, and we'll talk about syncope in refusing patients. So the definition of syncope is rapid onset of loss of postural. I'm going to say not loss of postural tone, but loss of consciousness. It's usually short, less than a minute or two, and then they return back to baseline as long as there's not a malignant cause for their syncope. Up to 3% of ED patients present with syncope, and what to pay attention to is that there's a marked increase in presentation for syncope with the older you get, especially at the 6th decade of life. It's classified into orthostatic, related to inappropriate, autonomic findings when the patient changes position of their body in space. So they stand up, their blood pressure or their peripheral vasculature does not vasoconstrict. They end up having hypotension, causing them to pass out, or reflex. Their autonomic nervous system is affected, or cardiac. There's an arrhythmia, either a STEMI, a rapid ventricular or supraventricular rhythm, or a block, or sinus pauses. They could have pulmonary hypertension or structural heart disease, such as pericardial effusion, or stenosis or regurgitation of one of their valves that can lead them to having a syncope episode. The history of the present illness and patient characteristics are really important to try to determine if this is a benign cause of syncope versus a life-threatening cause. The duration, remember, it should be short. The frequency tends to be more concerning if this is a multiple syncope episode in an acute setting. This is a patient with POTS, though they may have a history of syncope, so that although POTS doesn't eliminate you from ever having a malignant cause for syncope, it means that, this might be their baseline. Events leading up to the syncope episode, were they using the restroom? Were they bearing down for a bowel movement? Were they exercising? Were they scared? Were they emotional? All of those give you an idea of what classification this may have been leading to, as well as any associated symptoms. Did they have a severe headache and then they've passed out? Were they having neurological symptoms? Were they having chest pain or shortness of breath? What was the position that they were in when they syncopized? Were they standing up after being laying flat, or were they standing for a long period of time? Were they laying down when they passed out, or sitting at the table eating? So those would be questions worth asking, with syncope occurring not related to standing, or just when there is no postural change concerning for a potential malignant cause. Do they have any prescriptions that might be predisposing them to syncope, such as like Flomax or rate controlling medications that now lead them to be bradycardic and not have appropriate response when they stand up, if they're concentrated or dehydrated, and then any past medical history. If you have a older patient, especially in a patient that is in their 60s or older, that increases the odds of a life-threatening cause for syncope. So be aware of the age in regards to the history as well. This is just a image of a sinus pause that could lead to syncope and being rapid, short duration, and return to baseline. Management is going to be ABCs, vital signs early on to see what you're dealing with, 12 lead to evaluate for blocks, arrhythmias, or any other predisposing cardiac conduction issues. A physical exam is important, particularly paying attention to neurological, cardiac, and lung. If you hear a murmur, assume that that might be what's contributing to the patient's syncopal episode. Labs, I didn't put that in blue because we have ability to check a blood glucose, but there'll be more labs done, including troponins, electrolytes, kidney function, and signs for bleeding, as some of our GI bleeds that are occult, maybe pretty substantial, and we're seeing that they're passing out because they have a hemoglobin of 6. Chest x-rays might be obtained looking for dissection or aneurysms, a CT depending if we're dealing with something vasculature or pulmonary, and then a bedside point of care ultrasound can be performed looking for any evidence of valvular insufficiency, PE, pericardial effusion, or even dehydration, looking at the IVC and pure vena cava. So in regards to our protocols, I pulled up syncope, and it's a loss of consciousness and postural tone. I think the postural tone doesn't necessarily have to be the case from the review, so don't always say that it has to be with it. Resolving spontaneously without medical intervention. Patients may call this fainting or fall out. Typically, it's abrupt in onset and resolves quickly. You may find the patient to be awake alert when you arrive, or if they are never oriented at baseline, that somebody that knows them could say they're back to normal for them. Pre-syncope is the prodromal symptoms of syncope, and it's described as nearly passing out. Patients that are identified to have a single episode, you should be looking for underlying causes, looking for neurological issues, looking for any reasons for altered mental status. You're going to be treating per universal patient protocols. And if there's any abnormalities in the physical exam, you should be evaluating for cardiac dysrhythmias, cardiac ischemia, infarct, hemorrhage, shock. You should manage their airway, give them oxygen if it's necessary, evaluate for hemorrhage, treat for shock, obtain IV access, cardiac monitoring, not just a 12 lead, and monitor and treat any arrhythmias. Any patient that has suffered a single episode deserves hospital level evaluation. So all of these patients should be an AMA refusal, and high risk causes of syncope cardiovascularly could be an MI, valvular insufficiency in the form of aortic stenosis, HOCM, or hypertrophic cardiomyopathy, PEs, dissections, dysrhythmias, and then neurovascularly could be from a bleed in their brain, or it could be from a stroke, or it could be a TIA, among others too. And then again, patients refusing care. This would be if the patient had a single episode, it would be considered against medical advice refusal, which mandatory consultation of medical control. And have involved. So in summary, thank you guys for your attention. Should be the fourth one. I don't know where that's missing, but anyways, sub-Q emphysema from a post-operative procedure, evaluate if there's impending airway problem. If there's concern for pneumothorax and you need to intervene, then needle decompression is necessary. Patients that present with bradycardia or chest pain is concerning for potential ischemic issues, especially if it's an insult to the LAD that they may have bradycardia, heart blocks. So be prepared for that. Patients that have suffered significant facial trauma may have injuries to their face that are Lefort fractures, and the more severe the Lefort fracture, the more unstable and more bleeding you might be dealing with. So be prepared for difficult airway. If you're able to ventilate them with a supraglottic, that's fantastic. But if you must intubate and you can't ventilate, these are patients that get cricothyrotomies. And syncope is a recommendation to go to the hospital because although there's a range of benign to severe, we really don't want to miss the severe cases. So if they refuse, these are mandatory online medical contacts. References. All right. Thank you guys for your attention. If you have any questions, you can put it in the chat. You can email me, or you can reach out to me in any way that you already know how to.
Thank you, Dr. Gadbois. In looking, I don't see anything in the chat.
All right. Thanks
everyone
guys.